Very nice.
Okay. So first of all, I would like to thank you for giving me the opportunity to talk here. This is indeed a very complex issue, and I think we only can touch some of the big problems in this kind of surgery. And I will try to demonstrate a little bit the surgical strategies in correction of adult deformities. I'm sure that I can only touch certain issues, not everything. Something is clear when we start to talk about the surgery. There is definitely proven and demonstrated that when you really want to have a major change in these deformities, in the adult deformities of the clinical problem of the patient, it is surgery which brings this change, and there is no alternative, in fact, for surgery when the patient is really in a bad situation from his quality of life. This has been demonstrated with this study where they compared the SRS scores in conservative or non-surgical treatment against the surgical treatment. However, as we may hear, there is a significant complication rate, and the complication rate depends highly from the age. Younger the patient, less complications. Older the patient, more complication. I'm sure we're going to hear from you, Mehmet, about this. Now, the big problem there is, you can always ask what is new in this deformity surgery, because when you look at the literature, the deformity surgery is now one of the big things in the journals. Everybody's talking about, but what is really new? And I think there is new instrumentation and all kinds of things what you can use, but what is not new is the problems you have. The problems are still the same. It's the problem to correlate the clinical signs and symptoms with the morphology. And that's the reason, as we heard at the beginning, why we have many different classifications, any classification addressing special issues. But until today, I don't think that we have a global classification with what you can address all the problems in these deformities. Now, there is always this question, of course, how can we clinically relate to the morphology? And there has been publications about that. One of these publications is this out of China, which has been published in Spine, where they try to correlate the symptoms and the radiological findings. And they came up with 3 categories of patients who have primarily neurological symptoms, patients who have primarily deformity symptoms mostly is back pain, and a combination of both. And they think that this is an effective method in the surgical decision making. We go a little bit further. We try to correlate the clinical findings with the different issues you have in the deformity surgical. One, and that's certainly for everybody the same, this is the neurological deficit due to neurocompression. So you can have a neurocompression which is static, which has a corresponding morphology. That means you have a narrowing of the spinal canal, which is due to hypertrophy of the facet joints or whatsoever. And you have dynamic forms of neurological deficit or neurocompression, where neurocompression which only arrives under a load or movement. And this is, of course, 2 different things. And how you handle this is also different things, because very often the dynamic form is not something you can just do a simple decompression, but it goes along with maybe a realignment of the spine and the stabilization of the spine in a long distance fixation. Then we have the clinical finding of the back pain, which can be due to the deformity. This can be due to joint disease, disc disease, and is often also dependent from the posture and the movement. That means there is also in the back pain is a dynamic element. And the third thing, which is relevant in the context of this deformities, is whether the deformity is progressive or whether it's static. And there are deformities which are quite rapidly progressive, specifically in this adult de novo scoliosis. Sometimes this can go quite fast. And then, of course, As we heard already, there is a problem of this disturbed sagittal and frontal balance, which plays a major role when you start to talk about correction of the deformity. So you have to keep that clearly in mind. And that leads to the situations that you have to look at the different classification systems to finally streamline your indication for the surgery. So as we know, there is an etiological classification. It makes a difference whether you have an adult deformity, the adult scoliosis, whether this is a de novo scoliosis, which is a multisegmental disc disease, or whether you have a degenerative change in an adolescent idiopathic scoliosis. These are completely two different things, and the treatment is different. And then, of course, there is a classification which came up, and we have heard about the adult de novo scoliosis classification, which is specifically for this de novo scoliosis problems, which has been brought by Frank Schwab. As you can see here, there are elements which are relevant in the X-ray. That means when you have an allostasis, this is relevant for the outcome. However, the Cobb angle is not relevant, and the plumb line offset in the AP level is for this specific problem not relevant, but it's the angle, for instance, the end plates at the apex, which are relevant for the outcome, and therefore you have to include that in the classification or in the analysis of the case. And finally, for the clinical application, when you work then in the operating theater and you have to do the surgery, I think the classification of the so-called degenerative segment disease, which is specifically for the de novo adult scoliosis, the classification of Berjano and Lamartina is very helpful, where you have these 4 types, the type 1, type 2, and type 3. I will come back to that. And the type 4, which are the imbalance cases. So it makes a difference what you are looking at, whether you look first at the X-ray, and this gives you some impression what you have to do, whether you look at the etiology or whether you look at the way how you want to correct, where you apply instrumentation and where you may avoid instrumentation. Now, in the practical application, when we talk practically about when the patient stands in front for you, what is relevant? Relevant is, of course, whether the patient has, in the context of the deformity, an instability. And the instability can be in the frontal plane or in the sagittal or in both. It can be just one segment, or it can be a global instability, as I will show you. Is there a stenosis? Can be central or recessal. Is the deformity a combination of kyphosis and scoliosis, or is it just a scoliosis? And is it progression? And what is the condition of the bone? And with these 4 major issues, morphological issues, you have clinical presentation. The clinical presentation is always the same. It's pain, it's claudication symptomatology, and it's a neurological deficit. And the cosmesis doesn't play a role in these adult deformities. This is a very secondary problem. This is a more important problem in the adolescent deformity surgery. Now, when you take the stenosis, your primary problem, of course, is claudication and neurological deficit. And as you can see here, it can be, for instance, in a patient, as I will show you, just a prolapse of a disc in a scoliosis. And this may present itself as a dynamic problem, just under load or in movement. And it can be also a malalignment of the curve of the spine because of the pain. It's not a structured malalignment. It's a malalignment, a functional malalignment. So this is a perfect example for that. This is a 65-year-old male patient with a severe claudication and persistent left leg pain. He has a sagittal imbalance, which is functionally disturbed, as you can see on the right-hand side. And it is, however, not fixed. This is completely different because this is an adolescent idiopathic scoliosis. This patient had this curve for all his life. And his problem is not in the curve. His problem is at the level of L3-4. As you can see here, he has a mass prolapse, which is not in the convexity of the curve. And when you relieve this mass prolapse, the patient goes back in a normal alignment. So you don't need to do any correction. And this was just the treatment of the segment, which was the major problem, which was L3-4. We are not interested in this curve because this patient had this curve all his life. Now, another example of a spinal stenosis is an elderly patient, 79 years old, polymorbid female patient. You don't want to do major reconstructive surgery. This patient has a major stenosis at the apex of the curve, and through a decompression and a localized fixation, you may solve this problem because you don't want to have a major surgery in a 79 years old polymorbid patient. And for the functionality of day-to-day life, this may be sufficient for this patient. Now, when we talk about the instability, as I mentioned before, you can have an instability which is concerning the whole curve, or it's concerning just one segment. So if you look at this spine in a little bit more than 60 years old lady, she has a lot of problems when you look at this spine, but her major problem, in fact, is at the level of L3-4, as you can see. And she has, when you go with this classification of Frank Schwab, she has an allisthesis, a lateral listhesis at L3-4, which is the unstable segment. And to do that, to figure that out, whether this is really the problem, you may use certain diagnostic tools. So you can do infiltration for the facet joint at this level. You can do an epidural block. If you can, with a selective epidural block or a foraminal infiltration, you can see whether this segment is really responsible. And then you treat just this segment. You don't want to treat this spine with what this lady has lived for a long time. You just treat where the problem is, and you don't attack the rest of this curve. This is another example of a patient with an instability problem, as you can see at L4-5. This is a fireman with severe back pain and dynamic radicular pain, which has been just stabilized in this part where the major problem lies between L4 and 5, and has been stabilized, and the patient was quite happy with this problem. Now, the last thing is the progression. So here, for instance, we have an example of a patient which we can observe over 25 or 30 years. This patient, when she was young, she constantly complained about low back pain, and nobody was finding anything because this patient had, when this patient had first back pain, nobody did an MRI at this time. And over the years, you can see how this curve is developing. This is a classical de novo scoliosis, which is a disc disease. It can be first one level, but with time it is several levels, disc disease, and this finally leads to a significant deformity of the spine, which is here only the frontal plane, but of course, usually it goes along with a sagittal plane deformity. And this is differently to understand than when you look at other progression of a curve in an adolescent scoliosis, for instance. Here's another example of a very impressive progression of a curve of an adult de novo scoliosis. This patient, 57 years old, she had back pain, complained about severe back pain. This patient had some conservative treatment. She had a problem at the level of L3-4 and L2-3. And 2 years later, this patient is developing a kyphoscoliosis. As you can see, collapse of the disc space, both levels, and also a deviation in the frontal plane. So she has the full pattern of a de novo scoliosis, which will progress further if you don't treat this patient. This patient is in agony. She needs surgery. Now, the deformity by itself can be, of course, a problem, and this is here in a 60-year-old female teacher with a high demand in quality of life. She's otherwise very healthy. She wants to do sports and things like that, and she had an adolescent idiopathic scoliosis which has never been treated, but with aging, these joints, the deformed joints, because of the asymmetry of the load, created a lot of pain. back pain, but then also with time some radicular pain. This patient had an anterior release. This is some years ago when we did that, an anterior release and finally a posterior reconstruction, which is not maybe according to what you have stands today, not perfect. However, this patient did very well after this without any additional surgery. And you can see that the lumbar sacral junction has been reinforced with a cage, so the screws were only positioned in S1. Now, when we look at these different patterns, then it is obvious that we have to individualize the surgery. We have in the therapeutic decision-making, we have to look at each patient individually, and we use the different instruments, what I was just talking about, to basically define what is the surgery with the least amount of work you have to do, not because of you, but for the patient, because most probably less surgery is better surgery. Now, we can also talk about the different clinical symptoms, the back pain, the radicular pain, the neurological deficits, the spinal claudication, and so on. And we can apply different therapeutic measures. In all of these combinations, there is a surgical element. And as I said at the beginning, a real deformity which has a certain tendency to progress or compress the nerve components finally will need surgery. You cannot treat that with medication and with just physiotherapy. Now, when we finally decide that we have to do a surgery, then I think we have to look at this classification, which I mentioned from Bercano and Lamartina with these different types. So you have the type where you have a non-apical pathology. That means the pathology, as I showed already a case, is not really in the curve, it's beyond the curve. Then you have the pathology which is in the apex of the curve, or sometimes also in the apex and maybe in the segment in the neighborhood above and below. Then you have a curve which is a whole curve pathology, which is an extended curve, but still it's a curve which is mainly balanced. And then you have unbalanced curves, that means in the sagittal plane, which is the type 4A, and when you have a combination of the sagittal and coronal plane deformity. Now, let's see at the type 1, far from the apex, a non-apical pathology. This is a lady who was complaining about back pain all the time, 47 years old. She had, when you looked at her, she had a problem, in fact, at L4-5. She had different infiltrations, facet blocks, epidural blocks, foraminal blocks, and so on. And it could be identified that the segment L4-5 was really her problem with an asymmetric disc. And probably if you leave that over time, this may deteriorate. And in this specific patient, only the problem at where she had the most pain when you evaluated her has been fixed. And it's interesting, as you can see, when you look at the X-ray, you think you should probably also deal with the segment L2-3 or L3-4, but as it has been done, the surgery at L4-5, this patient was basically symptom-free and there was no progression of the curve, which is quite interesting that there are cases which are limited just to one segment. Then you have a case here of an apical problem. This patient has been operated several times before. And I think this is a curve, which is a type 3 curve when you look at the etiology, because he has a leg length discrepancy, as you can see. So her curve is a compensation curve. She has been operated several times in another hospital. They did decompressions and they put an interspinal spacer, as you can see here, but the curve was progressing. This patient had a significant radicular problem and back pain. And finally, she has been reconstructed with in the apex, but we had to include the segment below and above. And of course, you cannot treat this patient with this kind of surgery without looking at the equivalence of the pelvis. That means you have to give a shoe support. So otherwise, she will develop a scoliosis above your fixation if you don't deal with this problem of the leg length discrepancy. So this is a long curve, an extended curve. And as you can see, this is again a curve with an axial instability. Just several levels are not stable. As you can see on the traction film belongs to the basic evaluation of an adult degenerative deformity. And you can see here that this curve is basically relieved with the traction. And therefore, this is an unstable curve, which is an extended curve and which needs to be treated as the whole curve, as you can see here. And this patient has a significant osteoporosis. And therefore, here we have done some prophylactic vertebroplasties. You can argue about this. Also, the screw, the last screw, the end vertebra has been with cement augmented. This went very well, but we have seen patients where even with the cement, we have seen fractures of the adjacent vertebra or the vertebra with the last screw. So this doesn't prevent this problem, but in this specific case, it was very helpful. And then you have curves like this one, which is a combination. That means this is basically an adolescent idiopathic scoliosis which has been neglected in the lumbar spine. And this, she herself is a physician, and she came with 72 because of terrible back pain and some radicular pain. And in this specific patient, we also did some traction films. As you can see, again, there is some instability, axial instability, which can be demonstrated with the traction. And also in the frontal view, you can see the air in the disc, which speaks for this kind of instability. She has been corrected. She was very happy for the maybe 10 months. After this 10 months, she came back and she complained about neck pain. And we looked at the neck and we compared the neck with the x-rays we took before. And in fact, this patient developed a spondylolisthesis at L3-4. So that means for us, and I showed this case again and again, because we talk so much about sagittal balance and correction of the sagittal balance, this patient had a tendency to go forward in the forward bending, and the only localization where she could do that was in the cervical spine. So you can correct the thoracic and the lumbar spine, and yet if there is not the possibility to correct in the thoracic spine because she was very rigid, she corrected in the cervical spine. So the so-called balance is probably somewhere fixed in the brain. We have a certain pattern of our position, of our posture in the space, which is in the brain. And with a person of 72 years, probably you cannot change this completely. As you can see here, this is the MRI. This was finally the fixation we had to do in this specific patient. And here you see another patient which who has a malalignment in the frontal plane as well as in the sagittal plane. Here we did an osteotomy. We did a short fixation. As you can see here, with a pretty good correction in both planes. She's now 4 years down the surgery and she's doing well. She had no adjacent segment problem until today. So sometimes with relatively limited surgery, with an osteotomy where you can correct in a short distance quite a lot, you can deal with smaller surgery than with a big correction surgery of the whole spine. So in conclusion, the surgical goal, of course, is always the same. If you have a neurocompression, you have to do a decompression of the roots or of the whole dural sac. You have to stabilize, you have to create a solid arthrodesis, and sometimes you may do some corrections with osteotomies. You may do some restoration of the function of the spine. But at the end of the day, it's a constant challenge in trying to achieve the greatest benefit with the least amount of intervention. I think we will face more and more complications with these long fixations we do in these spines because we have the tools to do that. But many of these patients, they will come back after a very good primary result. You see them after 2, 3, 4 years then with a secondary problem, and for which we very often have no real answer. So I think it is very important that you individualize this surgery, that you look at the indications by addressing the main clinical problems, which can be explained by a morphology and by a reason. So the clinical picture must have a reason in the morphology when you want to do a successful surgery. Thank you.
Thank you, Professor Aebi. Yeah, very great lecture. We are learning and I'm very happy that we had gathered in this occasion the most expert speakers in one panel. Are there any questions, Onur?
May I?
Yes.
Aebi, thank you so much for this excellent presentation. At the end of this 40 or 50 years experience, what do you recommend us? We have seen you have lots of osteotomies. You have operated very severe kyphosis cases. We have to think about the patient. We have to decide according to the patient. But how can you summarize it?
Yes, you know, older I get, less I know. What I realize, you know, we have just at the moment, we have a very severe case in the hospital where we started to do basically a correction and fixation in the lumbar spine from L3 to the sacrum. And now on Friday, we did a fixation to T2, you know, and it doesn't stop. And we don't understand why, because when you measure this thing, the sagittal alignment is all as it should be, and yet this patient goes constantly in a deviation segment problem. That means she collapses above or she pulls out the fixation. So, you know, there are still things, and maybe we just collect these cases in our center where we do not know what to do. We are three spine surgeons, some with some experience. Yes, as you mentioned, I'm now 45 years in this business, and still we have situations we don't know what to do. So that's what I try to say, you know, that when you have a surgical indication, then you must have a clinical picture which correlates with the morphology. You cannot operate an X-ray. The clinical picture must be relevant. You want to treat the patient for his clinical problem. And then you have to see whether there is a correlation of the morphology, what you can see with the imaging. And sometimes it's very difficult to see what exactly is the link between what the patient complains about and what you see on the images. So I think we probably will never have a perfect solution for that. You know, as I just said before, we have now again a new classification. When Claudio explained it, it makes a lot of sense. But, you know, it makes the things more and more complex. And I think that at the end, probably we will have artificial intelligence to integrate all these elements maybe and help us to come to better solutions. But at the end, you as a surgeon are standing in front of this patient or in front of his bed, and you have to explain why you do the surgery. And this is not so simple. It's not simple. It's a very difficult surgery. It's easier to do just simple disc herniations and this kind of things.
Yes. And you want to stress that our interventions must be as minimal as possible. Do you?
Yeah, of course, that's what you probably want to do. But you know, there are situations where you have no chance. If you do a surgery, then you have to do major surgery, as the case which Claudio showed with the cervical problem, and the cases what Pedro showed. You know, but I think when you do this, when you come to the conclusion that you do this major surgery, then please bring people in the operating theater who know how to do that. You should not do this surgery when you have not somebody with you who teaches you this kind of things.
Exactly.
That's the problem, you know. We see that we have out of 10 patients I see in my clinic, 6 are at least patients who come for a second opinion because they had a surgery before. And many of these patients, maybe if you talk before, not after the surgery, you could avoid, you know.
Okay. There is one question from the participants. What about PJK? But I will deal with that in my talk about the complications. I think I will answer him.
Yes, I thought I will not speak about that because you are going to speak about it.
Okay. Can you please unshare your screen?